It's a great pleasure for me to introduce Jacob Stephenson, known to most of you. Jacob is a graduate of this training program, spent time with us in the lab, which is how we first met, and we were thrilled to be able to get him back into the Davis community after his military service time away. It's still an important part of his life, and he's going to tell us a lot about some of his experiences and how that impacts how we think about global surgery, particularly relative to kids. So, Jacob, thank you.
Thank you. All right, so no disclosures to talk about. I did want to give you a quick update. Last time I gave grand rounds here was in 2008, and we talked about therapeutic hypothermia for children primarily with hypoxic ischemic encephalopathy as opposed to trauma. And we talked about a case study who is now in the 4th grade doing great. So just a quick update. That's my son, Elijah. And I really appreciated all the support. When I was a resident here with a sick child, UCD was great. Anyway, so switching gears a little bit, we're going to talk about global surgery, specifically how it applies to children, specifically some thoughts on philosophy and different modes of delivery of care in global surgery. The first step will be to define the academic field of global surgery and look a little bit at the contemporary burden of disease. We'll look at some recent initiatives from last year, some big things in the world of global surgery and their impact on care for children. Talk about different models of involvement in global surgery and introduce some goals both locally and internationally that we're involved with as a department here. So I don't want to read from every slide, but this is an important one in terms of the words. So global surgery is defined as an area of study, research, practice, and advocacy that seeks to improve health outcomes and achieve health equity for all people who require surgical care, with a special emphasis on underserved populations and populations in crisis. It uses collaborative, cross-sectoral, and transnational approaches as a synthesis of population-based strategies with individual surgical care. So the big idea here is that we're kind of moving from an era of scattered doctors wanting to do the best thing for the world by committing their time and resources in an independent way, and trying to put that together with some academic relevance and maybe leave the end of today, if you didn't already, understanding that global surgery is a real and legitimate academic endeavor. So in 2015, there was a pretty big deal commission on global surgery put together by the Lancet. There's 25 commissioners and advisors from 110 countries that came together to sort of synthesize that current burden of disease and make some plans moving forward. Here's a couple of the numbers that they came up with. So 5 billion with a B people lack access to surgical care around the world. That's a big number. 143 million additional surgical procedures are needed every year to meet a minimum goal, which they defined as 5,000 procedures for every 100,000 population. So looking around the world at what's needed for surgical care, that's kind of a minimum goal. In addition to the 33 million people that are impoverished based on having to pay for whatever surgical care they have, there's an additional 48 million that reach an impoverishing level of financial insult because of lost time at work, lost wages, and this clearly applies to children as well and their families. And in calculating out the disability life years that can be gained back from surgical care, the Commission concluded that investment in surgical and anesthesia services is actually really affordable, more affordable in fact than condom distribution, more affordable in fact than tetanus immunization and other immunization outreaches in the world. And surgery is an indivisible, indispensable part of healthcare. So again, 5 billion people is a big number. The Lancet Commission called this the Global Surgery 2030 because of the goals to reduce that burden by the year 2030. And this is some of the estimates in terms of expense and cost on what it would take to do that. So looking at the best functioning of the low and middle income countries, if all the other countries were to adopt their models, we could actually meet 2/3 of the goal by the year 2030, and it would take $350 billion of investment. Also a big number, but compared to the $21 trillion of estimated loss by not doing this, the argument is that that advancement of surgery around the world is actually the financially prudent thing for the world to embrace. Along with the Lancet Commission in 2015, the Disease Control Priorities put out a third edition of basically essential medical care to offer around the world. Volume 1 is essential surgery, which is also a boom for surgeons interested in global health. And basically they say that 1.5 million deaths can be averted each year through essential surgical procedures, and we'll define those in just a minute. These essential procedures can be performed at different levels of care, and in order to accomplish this, one goal or aspect here is task shifting, which has resulted in expanded coverage. What that means basically is training non-surgeons to provide surgical care at different levels, and that's especially helpful in rural areas. However, despite some recent gains, disparities remain in mortality rates. That's largely related to intraoperative and postoperative deaths related to anesthesia complications. So again, with the focus of looking at surgical care in the global sense from all providers. So of these essential surgeries, there are 44 procedures identified as basically essential to every medical system, and some pediatric surgical examples are there. And that's weighted in different tiers of care. So the DCP has identified things like C-sections and things like colostomies as being first-level care, and complex anorectal malformations, while essential to correcting the children's congenital issues and adding to long-term good outcomes, it is a tertiary practice. So one question that comes up when looking at essential surgery is it really essential? Does every person, every child have a right to health care? Not to get into politics too much here, but going all the way back to 1949, the Universal Declaration of Human Rights does include the right to a highest attainable standard of care. However, over most of the last century, pediatric surgery was felt to be a luxury item. It was not felt to be an actual attainable standard of care. And as such, surgery in general, and especially pediatric surgery, has been somewhat of a forgotten stepchild of global health. But with the new initiatives, we are seeing and hoping for more investment into global surgery care around the world. So this is a kind of a simplistic way to look at a couple comparisons here. So when you look at mortality rate for 1 to 4-year-olds, this is pretty obvious. This is a whole continent of enormous mortality rates, and you can barely see the U.S. up here. So when the map is kind of constructed for those numbers, we can see that we're losing children in these low and middle income countries disproportionately. Meanwhile, the actual distribution of healthcare workers is almost exactly the opposite. This is sort of where the whole continent of Africa went when you reestablish the map based on how many providers are in these locations. So that defines essentially a surgical workforce crisis. So the U.S. has about 6 general surgeons per 100,000, plus additional subspecialists. That's not including the pediatric surgeons, the cardiovascular surgeons, etc. Sub-Saharan Africa has about 1 surgeon per 100,000 people. With high birth rates and low life expectancy, about half the population in most of these countries are children. Meanwhile, there's 1 trained pediatric surgeon for every 5 million children. So if surgery is a basic right to children, and children are hurting around the world, then the question is begged: who will perform it safely in Africa? How are we going to, as a globe and our part in terms of high-income countries, how are we going to help to make a difference there? So we'll talk a little bit about the models of surgical care, and I think there's a lot of folks in this room that have been involved in different aspects of global surgical care in all different arenas, and so we're going to talk about these kind of 4 basic categories as they're broken down here to faith-based missions, short-term humanitarian trips, usually affiliated with a non-governmental organization, military missions, and then partners and academic collaborations. So we'll do a quick intro, and then I'll take you through some personal experience. that kind of melds those few. So faith-based medical outreach has been the standard for years and years and years, dating back to about 500 years when the first medical treatment centers were established in low-income countries, primarily of Judeo-Christian ethic. These are usually focused on actually taking care of children and providing that clinical care. And about half of the health infrastructure in Africa is actually dependent on faith-based organizations, or was at least started by these organizations. And since 2002, there is a faith-based organization, which we'll talk about a little bit more, that's kind of changed that paradigm a bit for surgery, focus more on training than on care delivery. And PACS has trained about 50 surgeons at this point, in addition to 7 fully trained pediatric surgeons who are practicing in different places on the continent of Africa. Short-term volunteerism is probably the most common that you'll see, with wide variety of applications, from a single surgeon taking a couple weeks off of a busy practice and traveling, to a large team taking essentially a whole cohort from a hospital and providing all levels of care. The emphasis is usually on care delivery, but can branch into teaching, and is often geared towards specific conditions where we can bring all these resources to improve the care. There are some potential pitfalls, but it is really important to note that, as a friend described it, this is a time for the healer to heal. So there's really a benefit for us as busy surgeons, physicians, to step out of our technology-driven world, get face-to-face with a patient, and be able to actually do what real doctoring is. It's very encouraging, it's very uplifting, and there are personal benefits there. But we do need to prepare effectively to avoid some of the pitfalls of short-term volunteerism as they're listed there. Really important to coordinate with the host community and to think of the cultural backgrounds and the downstream effects of a visit that you may have on not only the people or the children you're taking care of, but the healthcare and the community as a whole. Military missions do have a different goal in mind. So I tend to refer to these primarily as hearts and minds missions rather than humanitarian. Not that they can't go hand in hand, but military missions usually have a motive of improving safety of the United States or our allies. So we're bringing medical care in an effort to win the hearts and minds and to support the work that's being done around the world. So that has some potential downfalls in that the goals don't always align with the needs, but we are able to bring some special expertise in disaster relief. And while, again, maybe a political thing that we would disagree with at times, but the military does have the potential to intervene to protect the vulnerable. So there is some component of stopping abuse of people that actually does lead to improved health. I think if the children in Syria could be protected by bombs, there wouldn't be as many injuries, etc. But that goes into a different talk altogether. And then there's partnerships and academic collaborations. These are long-term relationships that focus on knowledge exchange of building up the level of care in low and middle income countries, and additionally have some pitfalls that we need to avoid. What's been referred to as neo-colonialism, as us bringing our values and our culture potentially to the healthcare system that doesn't want or need that influence. So it's critical that this is a two-way exchange, and that the training of low and middle income surgeons is prioritized over the education of trainees coming from the United States. I think a lot of us here have benefited by being able to go to a place with a lower level of care and practice above potentially our credentials. But in order to do these partnerships well, it's really critical to focus on training the local population. So I'll show a few slides and go through some pictures and stuff from trips that I've been on. My involvement's primarily been at Bingo Hospital in Cameroon, and this kind of melds the faith-based short-term, because I go for short-time trips, as well as the academic collaborations. So this is a PACS training site with a 5-year general surgery residency program. in a pretty high volume place. It's not a bad place to visit. This is a beautiful valley in the rainy season. There's waterfalls that kind of cascade all through here. In the dry season, there's a rock up over on this side that looks exactly like Half Dome. It's a pretty nice place to be. A quick geography, that's where Cameroon sits. All the Ebola crisis was kind of over West Africa. Boko Haram is in Nigeria here, and then everybody knows what goes on in Africa above the Sahara right now if you watch the news. But Cameroon is essentially a fairly safe and stable country, but there are some obstacles to safe surgery that I identified upon just arriving. So it's an austere environment. There's poverty everywhere. Then there is no real national health system, or at least it's underdeveloped. Crowded wards, no ICU, limited diagnostic studies. Anyone who's traveled to an African hospital will identify with all these things. Typically, this is fairly typical for a good hospital in sub-Saharan Africa with large open wards and nurses making rounds and waiting areas outside of the clinic and the operating rooms. So this is Catherine, one of the nurses, showing what task shifting looks like as she lines up 4 boys to circumcise on the day after their birth and relieve the surgeons of that job. These are cautery sticks, real sticks with nails on the end that are heated up and actually do great for cauterizing the circumcision site. She can finish all 4 of these circumcisions in about 15 minutes.
Where was she yesterday?
So just a quick photo of some of the kids to think about the cultural aspects and the traditional aspects that come into play in terms of effective preparation. So open cooking fires are common. The family dynamics and the family structure in much of sub-Saharan Africa and many places in the world is very different than what you think of with liberated women and moms in the United States. The mothers always have to refer back to the elder statesman of their tribe who may have 10 other wives, and the survival of this child may actually hinge on whether this mom is able to survive and go on with her life. So there's some implications there that we don't necessarily think about coming from our first world background. But there's always resources to put into play. And at Bingo, there's 2 full-time general surgery staff, 10 surgical residents, and a really good anesthesia team. These are some of the residents from multiple different countries around Africa coming together for this 5-year residency, meeting in a room a little smaller, but kind of like what we're doing this morning. Basic OR pictures. And an anesthesia team, again, a bit of the task shifting approach with an attending anesthesiologist, a CRNA director of a nurse training program to provide anesthesia. And this is kind of what they have to work with for an anesthesia cart. One of the first trips I went on, we were using draw over halothane and had a cardiac toxicity to the halothane and had to do CPR on this little baby. And everyone in the room kind of stopped and got away. But thankfully, we were able to shut the gas off and bring the kid back and make some changes to not use halothane in children anymore, even though it is fairly cheap and accessible. And our anesthesiologists are masters at multitasking. This is the CRNA responsible for this kid who's putting an IV on the ward in the same room because he couldn't leave. And another operation going on behind the curtain. So over about 5 trips, about 10 weeks total. This is just a basic breakdown of cases that I was involved with at Bingo. And I mean, you can look at it. The point is that we were able to, with those resources, do some fairly major cases in a teaching environment. And we'll go over the kind of outcomes of those kids later in a couple snapshots. So this is a child with Hirschsprung's disease that was treated in the local community. You see obviously a big full belly, right? There's a bunch of little hash marks here. Those are from the traditional healers that usually are the first line of care that a family will take a sick child to. Unfortunately, this one is an incision that we recognize as a laparotomy done by a surgeon, but not a surgeon with pediatric expertise. And so they opened the belly, saw the big distended colon, popped it and let the air out, and then put a stitch in. So immediately the child was decompressed and fine, and they took the patient's money and sent them on their way. And then a couple months later, they were here with us with Hirschsprungs that had not been treated. Some ostomies that potentially could be done better and have been done better over time. And we actually use real old school x-rays, which is kind of fun to do a single shot distal colostogram to aid in operative planning for an anorectoplasty. And this is the only way I could find to hang it up and be in a position I could look at it during the operation. A couple other complex, interesting cases. This is a Lone Star retractor. If you ever find yourself in want, the sutures work just fine. And a Kasai procedure for a liver that all the liver surgeons in the room will immediately notice as probably not a great idea to try to save that, but without other options, you get stretched a little bit. This is a lot of what we do is a colorectal surgery, kind of a during and after for a coloanal pull-through. And I wanted to bring this up just because it's a reminder that pediatric surgery isn't as marketable, I guess, to the world in general as things like clefts and things like HIV treatment. You can put up nice pictures of a baby with a cleft and now is smiling after it gets fixed, and you can raise money. I don't know what to call this. If this is we can take some votes maybe, but Smile Train doesn't quite work. I don't know how to market colorectal surgery in kids around the world to raise funds, to raise awareness. So these children are often left without a voice, and that's something that we aim to try to make a difference in. A couple other tough cases that just kind of stretch some creativity and allow the surgeon to kind of stretch beyond your comfort zones a bit. So here's just a quick chart of outcomes looking at cases that have been done. These are all ones I was involved with. I just wanted to basically show the point that follow-up is important, that having people there to take care of complications is very important, and being involved in a continuing relationship affords you that ability to reach back by way of email and phone calls and to help deal with the complications as they arise. So there's a few pictures here that kind of highlight maybe some of the progress in terms of going from a single short-term surgeon to the teaching model to allowing the residents that have been trained to kind of take over. So when I first got there, I did a fair bit of this operating by myself because the guys were busy doing other stuff, running around. As time went by a little bit, I started to have some of the resident involvement in terms of watching and learning by observation. It's hard to recognize under the mask, but this guy is Jerry Brown. He's now a general surgeon in Liberia and was on the cover of Time as the Person of the Year for his involvement in the Ebola response last year. So kind of famous people in the room there. And then we can move on to one-on-one teaching assistant kind of roles of taking folks through operations until ultimately this is Gerald, and he's doing a pull-through on his own, ready to graduate. So we have increased the capacity there through focusing on teaching, and have during the couple years that I've been involved, 7 surgeons that have finished their training and returned home to their home countries, and those are photos of a few. So what are we doing at UCD, and where are we positioned at UCD? There's a faculty survey that went out earlier this year with actually decent response rate, 160 respondents. Obviously, it's going to be a little bit biased, but 60% are involved in some degree in global health, with almost about a fifth and a little over a quarter having obtained grant funding or been published. And our surgery department is very well represented. So I'm speaking to an audience that in a lot of cases has more experience than I do in terms of global surgery. Most of the activities related to the respondents to this survey are in clinical service and teaching through NGOs and some faith-based organizations. You guys probably know there are opportunities for resident involvement during the research years. We've had success in the past, and current research fellows that are doing some pretty cool stuff. Laura's got a Fulbright scholarship and an MPH going from Harvard, and she's working in Mongolia right now. Guy is away at the World Health Organization in Geneva, which is a pretty sweet gig, as a fellow working on humanitarian team development for care in conflict zones. We won't go into a lot of detail, but we have been working on a proposal through the UC Davis One Health, which is set up through the School of Veterinary Medicine to create an interdisciplinary academic track that will incorporate the School of Medicine with a few different tiers of experience, from short trips or even symposiums up to a full fellowship for folks from the Pediatric Department, Internal Medicine, Surgery, etc. I'm not sure where that is right now. We're waiting on some feedback from the Dean's office on kind of how that proposal is going, but we're hoping to be able to bring a little bit more of the academic preparation for global health to UCD. And kind of tie into the University of California Global Health Institute, which has some cool stuff going on that we could talk about offline, but I'm going to wrap up here in a second so we can take questions. One last point here. This is something that I'm looking forward to being a part of this coming weekend, and is an initiative for Dr. Farmer's period of president as APSA, the Global Initiatives for Children's Surgery. And basically, the idea here is that we're kind of putting together the stuff we've talked about up to this point, and bringing providers from the global north or high-income countries and the global south or low and middle-income countries to come together and address children's surgical needs by really looking for the insight of those who are on the ground, providing care for kids and seeing what they need. The initial meeting was in May of this year in London. Follow up this weekend in DC, and the hope is to put together a little bit more in terms of activism, advocacy, and guidelines for doing safe surgery for children around the world. So we'll wrap up and maybe have some discussion here. Global surgery is growing into a mature field of academic medicine, and some recent initiatives in the last year or so have really been essential in pushing that forward. But as a reminder, there's still 5 billion people without access to safe surgery, and 1.5 million deaths that can be averted yearly. So there is a real need, a desire, and some metrics that we can look at in terms of how we can improve on it. Multiple models exist for this. We talked about some experience with all of them. All have a potential for great value for the population and global surgeon. All have pitfalls to watch for if we want to be responsible about taking care of kids around the world. And UC Davis is poised for a leading role in global surgery, in general surgery as well as pediatric. I think that's all I got.
Thank you, Dr. Stephenson. As usual, you are your understated, self-effacing self, because he has done so much work that he really didn't even highlight on a personal level related to this, that it really is amazing. I also want to just take a minute to make sure that everybody knows, in case they don't, that our Dr. Young is going to receive the Humanitarian Award from the American College of Surgeons later this month in Washington, D.C. as well. And that is the highest award from the American College of Surgeons related to these activities, and it really reflects. Now, Alice, how many years has Heart to Heart been in existence now?
Since 1989.
So this has been a long-going, consistent effort that really is a model for how global surgical interventions ought to be done in terms of training the trainer and getting the buy-in of the institutions before you go. And if they don't have that, they don't participate in that environment. So really, I'm very proud of this. And again, one of these understated things that we don't celebrate as much as we should here at Davis about what are the outstanding things that our faculty do. So, Niles, I just want to publicly acknowledge and thank you for your work in that area. So that really is a great overview, and I think we do have time to take some questions about what's going on in the department and the institution, and appreciate you stimulating the conversation. So, questions?
Thank you.
Yeah.
So more of a comment than a question, especially for those of you who don't know him. Jake was a resident here. For his chief talk, it's clear he gives very inspiring talks. For his chief talk, which was like 7 or 8 years ago,
yeah.
He brought his son to discuss like resuscitation and neonates, and it was obviously very memorable. So, guys, that's a high bar to reach given your chief resident.
Yeah, that was an excellent talk, and a very nice one. One of your last statements, I think, is very important in the current era of attempting to reach out to all of these areas, and that is coordination between all the NGOs. It drives all of our funders kind of crazy because you have so many different entities, in some cases duplicating effort, in some cases wasting money on efforts. But from your own personal experience in Cameroon, I guess that's where you were, do you have any idea how many NGOs are working in the Cameroon area doing outreach medicine?
No, that's a great question. As far as throughout the country, I don't know. This is my involvement has primarily been at the teaching hospital that has become the National Referral Center. So there's no other NGOs functioning in that hospital or for that specific subset of patients. But your point is outstanding, and that's one thing that we don't have is a coordination of all these efforts around the world. There's movements to do that, but everybody does kind of want to create their own thing, do their own thing. They're all different motives. Faith-based organizations have different motives than Peace Corps or MSF or different State Department involvements. The motives are different. We should be able to get on the same page though, as far as the outcomes and the end goal being the same. And an organization is key.
Certainly there are environments where 3 different groups show up the same week and say, oh, I didn't know you were going to be here, and I didn't know you were going to be here, and all of a sudden you got people walking all over each other and not figuring out who's going to do the cases. And then people often don't think about displacing the existing surgeons for whom that is their private practice, their environment. An additional comment is we talk about global health and we think of it as only in the low and middle income countries, but there are a whole lot of people in this country who are equally underserved with poor access to care, whose outcomes could be measured by the same. I think we need a really good, Japanese NGO to come to the United States and take care of all the patients that we don't take care of.
Well, actually, my question was referring to that, your definition of global pediatric surgery, because I know in the adult world, a lot of the NGOs explicitly include the inner city underprivileged population, or what Bill Schechter does in San Francisco, for instance, in the Bay Area. What's the perspective? I know you showed these really spectacular graphs where the developed countries shrink to next to nothing when it comes to outcomes, but obviously that's just an average, so there's obviously segments that's still not going to be optimal. What's the perspective? It seems like they're pretty much excluding the domestic issue in Europe or even this time of year or whatever. What's the general philosophy in the global pediatric surgery environment? Is that the same as in the adult world, or is it more focused on developing emerging countries?
I think it's the same. It's a different argument potentially versus showing the workforce crisis around the world. We have an abundance of workers in the United States. So our message here is you got to take care of your own first, right? And that's a message to UCD without getting too much politics. But we've got kids down the street who can't come to UCD on an elective basis because their insurance isn't accepted here. That is wrong. That is global surgery, and that's something that needs to be addressed. But it needs to be addressed on a different level than trying to plan for trauma system development, plan for global pediatric surgical care, building a system up from nothing. So it's definitely a part of global surgery, maybe a different side of the conversation, though.
Yeah, it would really be an interesting exercise to do some reverse global surgery in this country, if you will, and how might we sort of embarrass our decision makers if we had an army of, visiting surgeons from around the world come and provide care across our country, all the places that we are not serving adequately. And maldistribution of workers is true in our country as it is in developing countries, for sure. That, if you go, there still are no pediatric surgeons in Montana. Well, that's not true. Montana has one now, but there are examples of that for all kinds of specialties around the world, and in this community. Yeah. The students here do a great job with, do a good job getting started with trying to reach out to many of our displaced populations that come to Sacramento and other places that really don't access care as well as we think they should, just even here. And I think Laura is just publishing a paper on her experience in Germany with some of the refugees that have come into the European countries and how they are trying to serve those needs. And that's a whole separate group that is sort of outside, and that's true in this country as well. We've taken refugees into a variety of places, but they don't fit into the established healthcare system very well. So how to manage those populations as well. And certainly all of our undocumented folks in the state of California also don't access the healthcare system. Whose problem that is a bigger concept, but a bigger question. Jacob, thank you again for all you do. That's a great presentation.